Manny Reyes. I am currently a fourth-year medical student at a medical school based in Virginia. I am embarking on this journey of medical education, particularly going into the virtual world, and I want to present this pilot project. This is my first episode where I cover a particular topic in medicine, specifically in pulmonary critical care, because that's the unit that I'm going to be on, to better engage and provide a new opportunity for learning. So basically how this works is we have an episode 1 here, with an approach to respiratory distress. And what you see here are questions. Each of these questions has a little triangle. What this little triangle is basically is a toggle. So basically what we have here is a way to enhance your learning through active recall. So what we do here is we ask a question: what is the name of this channel? Well, if you hit the little toggle, I'm working on it. I don't have a name for it quite yet, but this basically gives you an idea of how this feature is utilized. So for each of the questions listed here, there's a actual drop down with specific answers. So that's pretty much the premise of it. I really think it's a great way to engage the content. There's going to be a link as well provided to the specific page where you can actually go over it on your own and use it as needed. So just to get started here, let's talk about respiratory distress and an approach for it. Particularly, what are the key symptoms of respiratory distress? So think about these in your brain just for a few seconds, generate your own answer, and we'll go ahead and go over it. Key symptoms for respiratory distress include tachypnea, cyanosis, increased work of breathing, and obstruction. I put a mnemonic for it. I can place mnemonics here and there, and I think they can be useful sometimes. So the mnemonic is TICO. So tachypnea, respiratory rate greater than 20, cyanosis, usually changes in coloration of the skin, and that work of breathing, so as well as obstruction. Now, going into the next thing, what is the definition of dyspnea? Now, think about an answer on your own, and we have it right here. Subjective experience of breathing discomfort that consists of qualitatively distinct sensations that vary. At the end of the day, this is a very subjective experience, right? So this is something that individuals are experiencing on their own, apart from something that you're seeing as a clinician, and that's very important. This is the ATS consensus statement. Going into a differential for dyspnea. For differentials, my approach is really more so based on anatomy, physiology, and structural features. So thinking about a differential for dyspnea, we obviously think about the lung pathology and things that can affect the lungs, but also there's other systems intertwined in there. So think about the cardiovascular system, for example, those kinds of things. So think about some examples of differential within those systems and then other systems as well. And here we go. Well, cardiac, we have all these causes here. Just going to highlight a couple: myocardial infarction, acute decompensated heart failure, valvular heart disease can also cause dyspnea as well. And then you have many other causes as well listed here. Airway-wise, it's a little bit more divided because respiratory distress usually, particularly pertaining to the respiratory system, can be a little bit more complex in terms of structures. So airway structures, asthma, COPD, things like that, pleura, large pleural effusion, pneumothorax. In the alveolar component, we have edema, pneumonia, hemorrhage that can be a potential contributor. And then CNS-wise, cerebrovascular accidents, things like that, along with some other causes. Systemically, metabolic acidosis, secondary to sepsis, for example, but you can think about other causes of metabolic acidosis as well. And then more MSK, ALS, Guillain-Barré syndrome, and then also myasthenia gravis. Now, we've thought about these before, and I would recommend that you also revisit some of these questions and try to see what you generate on your own independently before looking into the answers. And then what is generally the approach for a patient for respiratory distress prior, very important here, prior to actually ordering tests? So let's think about it. Just logically, you're walking around the hospital with your team. You get a rapid response, and you go in to see this patient, right? You go into the room. What's the first thing that you need to do? And really, to answer these, just look at the patient first. That's really the most important thing. I think that can give you a lot of information intuitively, as well as objectively as well. So assess their ABCs, look for access if there's established access, and then think about it with, do they have a GCS less than 8? Do they have pooling secretions in their oral cavity? Do they have hemoptysis, severe hypercapnia? Are they showing that? Are they tiring out? Are they breathing really, really fast, greater than a rate of 35? Basically, are they taking a deep breath in like every second or two? That's a great way to kind of assess that. Or shallow breathing as well, something else to think about. These things would probably make me think about going in the intubation route, particularly just because you think about this patient and they're probably sick. The next thing that you want to think about then, if they don't have any of these things, all right, they can possibly receive supplemental oxygen via a non-rebreather. And what does a non-rebreather look like? Just for review, we forget things sometimes. We forget what things look like. There's so much, equipment in medicine, and I think it's just useful to have an image. So your non-rebreather. And going back, what is the approach for testing? So some of the testing, this is not a complete list. This is just a general list of testing that you can think about. But think about some of the testing you would want to order after seeing this patient. Maybe this patient doesn't have any of these things with related to like the GCS less than 8 or the hemoptysis or pooling secretions. They're working, and you gave them a non-rebreather to breathe, but they're not quite at that level. Think about EKG, chest x-rays, arterial blood gas versus venous blood gas, just depending on what kind of access you have. A CT, PE, if you're high suspicion for pulmonary embolism, you can consider a TTE as well, non-contrast head CT. If you're in an institution that has a great usage of POCUS, this is also a great place to incorporate that. And in your chemistry, CBC, coags, things like that. So this is just a general approach to respiratory distress. I think this is not a complete full representation, but I think it's a great place to start for early learners and to just kind of get the gears thinking about managing this acutely. So thank you for your time, and we'll see you on the next episode.